Coming up on the Doctor's Hospital podcast.
The emphasis is on the mammogram and the ultrasound to have an effective and early diagnosis.
You want to show them that you are empathetic to exactly what is happening. We understand that breast cancer is on the rise.
If 100 women come for mammogram, screening mammogram, the American stats say 10 of them are going to need some additional investigation.
Doctor's Hospital Specialist Clinic is where trusted and best care meets consistency and dedication. Let our expert specialists take you on a healthcare journey where warmth, compassion, and your well-being come first. From diagnosis to prescription, we are with you every step of the way, ensuring your peace of mind. Visit us today at Centerville Medical Center, Collins Avenue and 6th Terrace, and discover quality, compassionate healthcare at Doctor's Hospital Specialist Clinic.
Welcome to the Doctor's Hospital podcast. I am your host, Alexis Burrows, Marketing Director here at Doctor's Hospital. I am pleased to be joined by our esteemed imaging team today, here to talk about breast cancer awareness, screening, the whole nine. And I am joined by our Executive Director of Imaging, Dr. Sharma, our lead physician and radiologist, Dr. Pahwa, and our lead mammographer and radiology technologist, Monisha. Rolle. There you go. All right, so this is our esteemed panel, and we're going to talk through everything about breast cancer screening, what you need to know in terms of the background, when you should start, how often you should get it, and what you should do if you depending on the results that you get. So, welcome to the podcast, everyone.
Thank you for having us.
Good day.
Good
Thanks
day.
for having
Thanks.
us, Alexis.
All right, so let's start at the ground floor. Can you explain what breast cancer screening entails and why it's important in the process of early detection?
Breast cancer screening is done to detect the tumor in the early stages when there are no symptoms. So it is done on the patients without symptoms. So we try to detect these lesions in early stages so that we can manage them. The management of the breast cancer is clearly determined by at what stage it is diagnosed and how much is the spread at the time of diagnosis. So earlier it is, better it is. So that's why it's really, really important to detect them early. We don't want to wait till we see any lesion, you can palpate it, and then we come for the mammogram. It can be really, really late at that point. So we want to start the screening at an appropriate time in a target group so that we can detect them early and manage them effectively and get a good response.
Yeah, I know it's been a recurring message, and I think almost every podcast that we've done this year, no matter what health topic it is that we've talked about, the importance of early detection, because obviously the earlier you find something, the earlier you can start treatment, and inevitably what you want to be able to have is better patient outcomes. So Dr. Sharma, can you tell us at what age women should start getting regular mammograms and how often should they be screened? And I guess, what may influence that?
Good day, Alexis. Thanks for having us here. So that's a great question. And interestingly enough, there is debate on this question. So if you go across the world and you look at screening programs which are in Europe, Americas, and Latin American countries, there is a differentiation in terms of the age groups which people recommend or societies recommend in terms of initiating screening. Now, and that's a diverse age, so it can be anywhere between 40 to 84 years of age, right? So that's how diverse it is. For example, in UK, screening starts at 50 and stops at 69, right? Extended to 74. Whereas in the US, there's increasing support and recommendation for starting at 40.
Okay.
Again, stopping at 74. Some recommendations stopping at 83. So as you can see, there is that ambiguity and lack of specification. The reason why that is because every country and population demographic has its own prevalence and incidence rates. And as we know, breast cancer screening involves a little bit of a radiation burden, and there are some other components of it, which we'll talk about as we go down this podcast. And because of that, the screening guidelines vary.
Mm.
But based on data which we know exists in the Caribbean, specifically that in the Bahamas, I think it is safe to say that annual screening mammograms starting at 40, right, and walking into at least 73 would be appropriate for the Bahamian population. Now, that being said, there are opportunities to even start screening earlier than that,
Mm-hmm.
because there is known statistic of earlier onset of breast cancer in this population, and the aim being obviously to detect cancer not just when it is smaller, but it's as well as when it's in the early stages. It would be prudent to start screening early, but it's a risk benefit analysis, obviously, and as of now we stick with 40 as the beginning of screening mammograms in the Bahamian population.
Okay. Um, so obviously we're talking about mammograms, but I know there are different types of imaging technologies that are used for breast cancer screening. That's one of them. Dr. Pahwa, can you kind of walk us through what some of the different types of technologies are that are used? How do they compare? And then like, what are the use cases? So what makes you use one technology versus another?
For we can use MRI and ultrasound apart from mammogram
Okay.
as a screening modality. But when we compare different factors, at present we still keep mammogram as a primary modality of screening. So what happens with the ultrasound is it is difficult sometimes to compare the two breasts together, keep them side by side, because one of the very important feature which we look for is the architectural distortion. So ultrasound sometimes can miss that.
Okay.
Second, when there are some very early features of small calcifications, we call them microcalcifications, those can only be picked up on mammogram because it's a X-ray kind of technology and it picks up the calcium, which we can miss on ultrasound.
Okay.
Now, when it comes to MRI can pick up and also diagnose to some extent and give us a very definitive answer. But when it comes to MRI, it entails giving contrast to the patient.
Right.
One patient need to lie down in a prone position for a long duration. And then it's not cost effective. And also the time which patient need to spend, that's also long. And it's not an effective screening tool then. But yes, there is an indication where we use MRI as a screening tool when there is a high risk patients who have a first family member cancer positive with a BRCA antigen. BRCA is antigen which determines the chances of getting cancer during your life. So if we have the patient, we complement our mammogram with MRI.
Okay.
And especially if there is a really, really dense breast and a high risk patient, we do both.
Okay.
So as to diagnose it and find and screen and detect it early.
You mentioned the BRCA. I think people refer to it as the BRCA gene. Is that something that we can test for in terms of, knowing if someone has that? Is that something that's offered to kind of help through, I guess, making it easy to determine which modality you should use? Because obviously that's a part of determining if you use the MRI versus the mammo versus the ultrasound. Is that something that we can test for?
Yes, that can be tested.
Okay.
And we determine whether the patient needs that test or not on the basis of the history which we take before doing a mammogram. And on the basis of that, it can be advised.
Okay.
There are specific indicators and there are tools to decide if the patient is in the high risk. Then we try to find whether the patient has a BRCA antigen in
Mhm.
them, mutation, or if their first relative has already, we
Okay.
automatically that patients qualify for the high risk patients.
Okay. Understood.
If I may add some
Sure.
statistics to that, Alexis. So, interestingly enough, and I think it's important to know the numbers here. So, when you look at screening mammogram individually by itself as for the general masses or for the population,
Mhm.
this is asymptomatic women who are otherwise healthy, not feeling anything, walking in for an examination.
Right.
Screening mammogram picks up 6 to 8 cancers per 1,000 women, right? So
Okay.
that is its detection capability essentially.
Okay.
That's the limitations of screening mammogram. It will pick up 6 to 8 cancers per 1,000, right? Now, when you add a complementary tool like ultrasound to it,
Mhm.
then you can add 2 to 4 additional cancer detection
Okay.
per 1,000. So you are going to notch that up to 10 to 12.
Okay.
There's another modality called tomosynthesis or the 3D breast mammograms, which have become in vogue now. They have some advantages for dense breasts, and they also have some advantages with regards small lesions which may be masked. So they detect slightly more than your 2D mammogram. So 8 to 10 per 1,000 is where breast tomosynthesis sits, right?
Okay.
So when you complement ultrasound to tomosynthesis, you're notching that up to 12 to 14 per 1,000. What's interesting is MRI, which, like Dr. Pahwa mentioned, it has its limitations, but there is a huge move, and this has been ongoing for some time in the States as well, with regards trying to get the insurance companies to approve MR as a screening tool. And MR can pick up 40 to 60 lesions per 1,000 mammograms.
Oh wow.
So that just tells you how extremely sensitive MR is as a diagnostic tool.
Mhm.
However, with the limitations of the time required for the exam, the cost prohibitiveness,
Mhm.
as well as lack of compensation from the insurance companies, there's not been that much of an uptake. But there is definitely a universal push towards making MR as a screening tool, especially in high-risk women, with those with dense breasts, those with significant family histories, and those with gene mutations. And talking about gene mutations is an interesting statistic which I came across. So the National Cancer Society started gene testing, I think, in 2014 in the Bahamas. It came in the papers, and they started with a small subgroup, but it has kind of caught on. And interestingly, the Bahamas has a very high prevalence of BRCA1 and 2 gene mutations, sitting at about 24 and 27% respectively. That's 1 in 4 essentially,
Mhm.
right? And what that means is that a lot of these women are going to have early breast cancers, right? In the age group of 40 to 59, as opposed to going into the age group of 50 to 73,
Right.
which is where the non-BRCA gene mutation cancers tend to happen. So that kind of pushes you into the need for aggressive screening and early screening
Mhm.
in the Bahamian population.
Yeah. You know, I guess kind of riding on the statistics just a little bit more. Because I know a couple of people personally, people who I know through social media and things like that, and it seems like you're seeing more and more women, even in their 30s, developing breast cancer. And I imagine this might be some of the push towards the lower age for starting screening. But what do you do in that instance? Because what do you say to somebody? And I guess does that play a role in when they start screening? So if someone has a family history and maybe they're aware of the gene and they've done some testing and they come in as a 35-year-old and they're like, hey, am I able to get screened? Having that concern, like what does that look like?
So yeah, that's a common problem actually. I'd get often called by both physicians and patients on this query. So this is a gray zone, to tell you the truth. One of the numbers there which becomes relevant is the radiation burden of a mammogram. Now, a 2D mammogram, which is 2 views for each breast, entails about 4.5 milligrays of radiation to a patient in an annual screening. 4.5 milligrays computes approximately to 2 months of background radiation, which you would get from natural sources, let's say. So in that scenario, the risk benefit analysis obviously favors that, yes, you're picking up cancer. However, because the data shows that the highest benefit of reduction of mortality as well as life improvement in lifetime expectancy happens when you start screening at 40, the question then becomes, what happens to the women between 30 to 40? Do you screen them with mammogram or not? You would need really strong risk benefit analysis to support that screening at 30, right?
Right.
The data is not there yet, right? However, if someone does come in, you have to offer them ultrasound as the first instance, knowing its limitations. That's not going to pick up microcalcifications. It may miss asymmetric densities because you're not comparing the two simultaneously. But relying on the fact that it will pick up small lesions, it will pick up some amount of architectural distortion. It may pick up, complex cystic masses. So there are some things it will, but there is a huge gap there. And that's where the MR again fills in that gap. And like I mentioned, it's a very, very strong diagnostic tool, picking up like 40 to 60 cancers in 1,000 women population if you were to use that as a screening tool. And in that dense breast, high risk population, I think MR is my go-to investigation, especially if the insurance covers it, the lady can afford it, and she's willing to go through that. You may have the opportunity to even alternate ultrasound and MRIs on an annual basis, taking advantage of both modalities, right? So you kind of split the cost between them as well as make sure that there's continuity of screening. So I would be as aggressive as the patient demands, right? So that's you have to determine it on a case-to-case basis. And not generalize that in that age group.
Right. Fair enough. And I imagine the alternating screening modalities also allows you to reduce the radiation burden.
Definitely. Yeah. Okay. With ultrasound and MR, there is no radiation involved.
Oh, right. You're right. Because you're saying you're not doing the mammo at that point.
You're not doing mammo at that point. I would be really guided to do a mammo if the ultrasound and MR suggest that there's something I would see on a mammogram. And Fair enough. There, we would probably try and do one view or the necessary exam as opposed to a full exam, right? So that becomes a diagnostic mammogram as opposed to a screening mammogram.
Okay, fair enough. So, Monisha, as a radiology technologist, can you walk us through what a typical mammogram procedure looks like for a patient?
Sure, Alexis. Once patients come, majority of them are coming directly from their physician, either from having an annual procedure done. So once they reach to the department, they would come with their request forms. For those who do not have a request form, we provide them with one as long as there's no complaints. And also we make sure that we do have some type of physician attached to it, mainly so that at the end of every exam, you do have someone that they can follow up with at the end. And once they come, especially if they are not experiencing any complaints, we do go through a questionnaire as well. Just like how Dr. Sharma mentioned in regards to the family history, we do need to know exactly if there is any family history, whether it's on your mother or father's side. Also, just like menstrual history, for instance, as early as childbirth, age that everything started, if there's any implants, are you doing your regular physicals, regular checks? So those type of things we need to know ahead of time so we know how to proceed. Also, once patients are dressed in the room, we do the standard procedures, which is taking the 2 set of images per breast. So the 2 images are the CC views, which really means that it's from top to bottom, just to capture the front portion of the breast. And then we have the obliques, which start from the middle to the outer portion of the breast. And like Dr. Pahwa mentioned earlier, it's easier for us to be able to do it through the mammogram because you can see them side by side. And once the images are completed, if it's not for any type of complaint or if there's nothing visible on it, then we are allowing the patient to leave and we follow up with them with their results directly for their physicians. But if there is something, then we do additional testing at that time as well, whether it is magnification views or spot views. We do additional exams just to make sure that everything's covered at that time.
I mean, I know this is something where people talk about, or if you've not done it before, there's a fear of like potential discomfort. How, I guess, for someone who's going through it, how comfortable or uncomfortable, like, how would you describe that? And then encourage people to still, kind of move forward with having the mammo done.
Well, a lot of persons that come in, they automatically come with that fear because someone else told them about it for the first time and their experience. So what I do is just make sure, get them to understand that everybody has their own experiences, but they trust me enough to be able to comfort them. And I ask them to just relax a little. And once you're doing it, literally you can have a mammogram and be in and out of the room in less than 5 minutes.
Oh wow. Oh, I guess that goes to the counter to the time it takes for the MR.
Absolutely.
Yeah. Okay. So I guess just curiosity about the size of the team. How many people do we have on staff that are able to do the mammo test? Because I know we're obviously into October now, into breast cancer awareness, and screening is going to be talked about here, there, and everywhere. So what does that team look like, and what does a typical day look like in terms of doing mammos, especially during the height of this time?
Well, at a regular day, we do mammograms by appointments from the hours of 8 a.m. to 3:30 p.m. And we do allow walk-ins as well. So you can imagine we can go through 20 plus patients, especially during the month of October, because everybody usually waits until the October time comes around for Breast Cancer Month. Yes.
Okay.
So we do have a lot of mammograms for the radiologist to read per day, especially during that season. And like I said, we do encourage walk-ins as well. So we can go through, a team can have about 7 to 8 females, and it just depends on who's scheduled at that particular time, because all of the females in the department are skilled enough to do the mammograms. So we take turns and we rotate around. So if someone is assisting with the questionnaires, just to help persons who are in need at that time while someone else is doing the actual exam. That way we can reduce the delay of the patients.
Right. And you're also doing this in the midst of any other screening or imaging tests that people may need to just naturally do in the flow of business in the day in the imaging suite. Correct?
Yes, sir.
Okay. All right. We are...
I would like to add a couple of things there.
Sure.
So, firstly, we are actually acquiring and we will have for this promotion, the new tomosynthesis machine.
Nice.
SG Pristina. I'm really looking forward to offering that additional 3D imaging services to our patients. That being said, this exam's still tailored. The reason I mentioned so is because the breast density actually really determines the need for tomosynthesis. So it's not that every patient will be a candidate for the same.
Right.
Primarily aiming to do that for dense breasts. Secondly, which I also wanted to mention towards the technologist pool, we have 7 to 8, I think, rad techs, female rad techs who are all trained on mammogram and adequately trained in that capacity with certifications and CMEs, which they need to acquire on an annual basis. But also beyond that, I think speaks to patient experience and surveys and all of our technologists have really been extremely competent and extremely great in this service, as is evident from the recommendations they get from patients on a frequent basis. And I think that experience is very important for someone who's coming in with the anxiety and fear in that space. So I really recommend them and commend them as well for all that they do. I think the last year statistics would speak to an average 30 plus mammograms daily, not 20. It was probably 30 plus. And we do open 6 days a week, except Sundays. We are offering mammograms Monday through Saturday.
Yeah, so there's a lot of opportunity for women to be able to come in and get the screening done.
Definitely.
Awesome.
Yes,
All right.
And that I just wanted to add, like, Monisha, can you tell, like, since how many years you're doing the mammograms?
I've been with Doctors Hospital now 19 years.
I still don't believe it.
Now imagine. So this is a very important aspect which we need to understand, that we have technologists. Those have been doing mammogram at the same institute over here since last 10, 12, 15 years. So when the patient comes, so they recognize them. and they also recognize the patient.
Mm-hmm.
So the anxiety, the questions, and other things are automatically very, very less, and their comfort level is very, very good. So sometimes they come and they ask for Monisha only. Sometimes they come for us for another technologist.
Right.
Oh, she did my mammogram last year. Where is she this year? So that's a kind of a relationship which we have because we have a constant technologist over here for so many years.
Right.
That is very, very important in mammogram because it is something when you meet someone, you don't want like to be comfortable enough to discuss your personal history, your private history. So, and suppose someone had some episode of detection of any nodule in the past which was removed. So, if the technologist was there, he knew that or she knew that, okay, this was done, we know about it. So, that's comfort is very, very important.
Yeah.
And the trust which patient has because of that.
Yeah. So I mean, like you said, it speaks to the consistency, just the you know, it's like Malcolm Gladwell's book, The Outliers, talks about doing 10,000 hours. So when you have someone who's been in the field for so long, who's probably done who knows how many mammograms in 19 years, I imagine you've done quite a few. But the idea is this is the level of expertise, and then obviously you speak to the comfort level of you see that same face every time you come, and there's an ability to let your guard down and feel comfortable going through the process. Which I imagine if you can kind of ease that anxiety coming into it, helps to make the whole process smoother, because when you're relaxed, you kind of just have a much better experience anyway. All right, we are having a great conversation with our imaging team here talking about breast cancer awareness. We'll take a quick break for some words from our sponsors, and we'll be right back on the Doctors Hospital podcast.
Are you seeking exceptional healthcare beyond the traditional hospital setting? Introducing Doctors Hospital Clinics, your trusted destination for comprehensive care. Our full-service locations provide affordable services through our Loyalty Advantage membership program and NHI. Experience seamless care with our integrated health system, where your medical history travels with you, ensuring continuity of care. Book an appointment today at clinics.doctorshosp.com. We make primary care easy.
Welcome back to the Doctors Hospital podcast. We are continuing our conversation with our amazing imaging team from the imaging department here at Doctors Hospital about breast cancer awareness and breast cancer screening. And we are going to continue with what I think is a very important question, because I think a lot of times when people think about screening, there's all kind of reasons and excuses as to why someone may not want to do different types of screening. And so, a lot of that sometimes is rooted in myths and misconceptions. Monisha spoke to one of them a little bit earlier about potential discomfort and things like that. So what are some of the other common myths and misconceptions that people may have specifically about mammograms, but even more broadly about breast cancer screening? And how would you refute or dispute those myths or misconceptions?
True. Thanks, Alexis. So they are very common to come across myths and misconceptions in the screening space. And I thought I'll look out for some of the common ones, and I have a list of about 6 which are really spoken to in the masses, and a lot of hospitals speak about these as well. So the commonest myth I have here is if I don't have any symptoms of breast cancer or any family history, I don't need to worry about having an annual mammogram, right? So obviously that is wrong. We know by statistics world over that 1 in 8 women run the risk of breast cancer in their lifetime. It has not necessarily got any genetic predominance. Even though there is a genetic component to it, there is a huge plethora of environmental factors which predispose women. So just by the fact that someone is a female gender puts them at average risk of breast cancer. So screening has to happen irrespective of whether you have symptoms or family history. Actually, if you have symptoms, then probably we are looking at late disease detection. So you want to pick it up before things happen. Myth number 2, mammogram will expose me to unsafe radiation. So I spoke to that. 4.5 milligrays is essentially 2 months of background radiation. And in terms of risk-benefit analysis for early cancer detection, definitely that has been established by all societies world over that it's an acceptable risk, which has no lifetime significance in terms of radiation damage. Common myth again, a 3D mammogram is the same as a 2D mammogram. yes, there are differences, and I spoke a couple of those in the earlier questions with regards 3D mammogram picking up smaller disease as well as masked disease because of its ability to split that dense breast into smaller sections, essentially. So that allows 3D mammograms to pick up slightly more amount of cancers in terms of general screening, with not a very big difference, but there is a difference. Like I mentioned, it goes from 6 to 8 per thousand to about 8 to 10 per thousand. So it's able to detect cancers at a slightly higher rate. Myth number 4: if I have any type of cancer in my breast, a screening mammogram is guaranteed to find it. Again, that's an important point to address. Screening mammograms are very sensitive, are definitely recommended. You have to do them annually, but not everything's going to get picked, right? We have to be aware of that some of the scenarios where you are going to need additional investigation, or you may be called back in 6 months' time, or you may have a biopsy or some kind of an intervention to actually confirm or diagnose that breast cancer. So, not everything's going to get picked, but that does not mean that we do not do it. It is the most essential and best screening tool we have. Myth number 5: I had a normal mammogram last year, so I don't need another one this year. So, like I mentioned, there are screening guidelines which vary across the planet. There are some countries which screen once in 3 years. There are some countries which screen in once in 2 years. But knowing the population, like I mentioned, we have a prevalence of about 220 per 100,000 women. The entire Caribbean actually has a high prevalence of breast cancer. About 15,000 breast cancers get diagnosed annually in the entire Caribbean. So, knowing that, annual screening is still the way to go, because having a normal mammogram today does not mean that there cannot be an interval growth in 6 months. We want to be able to pick it up as early as possible. And lastly, I have another common myth is, if my doctor didn't tell me to do a mammogram, I cannot schedule an exam. Again, screening tools are designed such that you can walk in and have a mammogram. If you don't have a physician, we'll find you a physician. You don't necessarily need a prescription. You don't necessarily need a physician to write one exam for you.
Right.
If you're 40 years of age, you are a candidate for screening mammogram. You just walk in and we will do the rest for you.
Okay. So you don't need a physician requisition.
Yep.
All right. Understood.
And just wanted to add, there is another myth, like mammogram cannot be done during breastfeeding and during pregnancy. So if there is an indication, yes, it can be done, and it entails very low radiation risk.
Okay. Understood. All right. Monisha, let's go back to you for I guess another conversation around question around the patient experience. How do you approach patients who may feel anxious or fearful about getting a mammogram? Whether that's because of fear of discomfort, fear of what the results may say. Given that you've been at this for a very long time, how do you approach that, and how do you help to ease the nerves of people who are getting mammograms done?
Well, to ease the nerve, we all have to start by building that trust. Whether it's the first time you're seeing the patient, or if this is someone that's been coming numerous times every single year, you start off by building that trust. You just encourage them to let them know that the purpose for the mammogram is so that they know exactly what's going on and if there is anything that you would need to do further. But you want to show them that you are empathetic to exactly what is happening. We understand that breast cancer is on the rise. So we just want to make sure that everything is good from the beginning, but you want to talk to them as if that's your sister, your friend, your mother. So you want to make sure you build that type of relationship with them. And then that kind of eases a lot of the tension that they might feel before getting into the room and actually getting started as well.
Okay. One of the things that I think we always look at as we discuss these types of topics is, what's coming down the line in terms of advancements in technologies, whether it's, and obviously we're talking more so from a screening perspective, but Dr. Sharma, obviously given your role, your amount of many hats right now at Doctors Hospital, one of which sits in the space of innovation in particular. So what advancements in breast cancer imaging screening have you seen in recent years or what is coming down the pipeline, and how do you anticipate that they would impact patient care, or, like I said, the screening process?
Great question, Alexis. So, a lot is happening actually in the screening space as well as in advancements technologically. And I'm going to list out some of the really impactful ones. For example, now the 3D tomosynthesis space has been expanding rapidly. It has kind of become the gold standard now as a screening tool. This movement is about 10 years old, which has got traction, and because of the earlier cancer detection in dense breasts and its ability to resolve smaller masses, it's something which we really want to consider as the go-to screening and examination. Secondly, there's a real significant advancement with CAD. CAD is computer aided detection. Now, CAD has been around for 20 years. CAD is not new in that sense. However, the ability to rely on CAD is now definitely much higher. So it's essentially a computer algorithm which is able to look at data sets, which may be about, let's say, 32 image per breast in a tomosynthesis, or a single image on a 2D, and be able to pick out microcalcifications, architectural distortions, asymmetries, masses. So once those are highlighted, they're not just highlighted in terms of the lesion, but they're also highlighted in terms of the possibility or percentage of cancer risk. So, it kind of grades it for you, whether it's a BIRADS 2, which is benign, or a BIRADS 3, which you need to follow up, versus a 4, which could be a cancer. So it's able to grade that. But not only are we seeing that grading happening in mammogram, actually CAD and analysis of images is happening in ultrasound. You can throw an ultrasound to AI software and can actually pick out lesions and grade them in terms of cancer risk. It's also happening in MRI. So you can get lesion detection support as well as lesion grading in terms of cancer risk on MRI images. All of these essentially reduce the time required to read scans, allowing the radiologist to focus on true pathologies as well as be able to screen bigger number of patients or throughput. That said, there are also, like I mentioned, MR is getting that advanced support and push towards being a screening tool, which is, I think, a great push, especially for dense breasts, younger women, those with family histories, as well as those who have proven breast cancers that are in a slightly higher risk of developing breast cancers in the immediate future. The BRCA gene mutations, obviously, like I mentioned, puts patients in a higher risk as well. So if you have someone who's had a gene mutation or proven gene mutation, you're able to screen them with MRI. There are advancements which are happening in the post-care space as well. So again, because of the availability of big data analysis now, they're developing databases where cancer detection then leads to that creation of an information pool with patient demographics, types of cancers, what treatment they got, not just surgery, but also the radiation and chemo, and be able to now create a personalized treatment for the next patient based on that big data analysis. So that and essentially now allows each patient to have the best outcome based on millions of data points which have existed in the past. Because that now becomes a personalized medicine or a unique case scenario for each patient based on what kind of cancer they have, what is their demographics, how what stage they were detected at. So the better outcomes are evident in the near future as more personalized medicine becomes part of routine care in breast cancer.
Right, because you can see the trends.
Yep,
with all
that's
that,
happening.
with that much data, you have the opportunity to really look at trends and be able to kind of have an idea of where something may be going and what treatments may be best.
Yes.
Awesome.
And I
go ahead.
just wanted to add to that. Also, we have what you call the ultrasound elastography. That's also a technique which is gaining a lot of importance. What it does is it try to estimate the firmness of the area, how firm the area is. So the more firm the area is, chances of this being neoplastic is more. So, and second, which is also that's still an experimental tool, is a contrast enhanced mammogram. That's
Okay.
also gaining. Then there are nuclear medicine also with the PET CTs and all that. But again, it's still an experimental, but people are experimenting with new things to find out better ways and effective tools too.
Yes, I know. When my mom was diagnosed, we actually got a PET CT done to stage where she was in the process. So I know that's where that fits into the overall overall picture. Yeah. Um. So I think the obvious next question becomes, and I'll ask this to you, Dr. Pahwa. What should a patient do if a mammogram or any of the screening tools detects an abnormality, and how does imaging guide further treatment decisions?
Yes. So once the mammogram is done and we find an abnormality on the mammogram, so there is a grading involved into it, like how definitive we are on the mammogram, whether that lesion is clearly cancer or it's not a cancer but looks like a cancer, or we have a suspicion but we can't say for sure. So, but we detected something which we are not sure, and we need to do additional imaging. The second stage is we complement that with the ultrasound. Now, on ultrasound, once we see something on mammogram and we complement with the ultrasound, on ultrasound we are able to actually see the lesion. So we become more definitive. On most of the cases where we see abnormality on mammogram and we have a high suspicion, we do ultrasound, we see the lesion, and the second part we discuss with the physician and we go for ultrasound guided biopsies to take a small sample of it and see it under microscope. And if it is malignant, then person can go for the management after that. Now, there could be a scenario where the lesion is not limited to the breast. It can go to the lymph nodes or it can spread to other areas. So, depending upon which stage it is, we might need to go in for the PET CT scans or MRI to see if there is a disease in the contralateral breast, depending upon what kind of tumor we are or what kind of neoplasm or the disease we are dealing with. So we need to investigate the extent of involvement. First is the localization, and then we have to see the extent of the involvement, and then we go for the management. So as far as the imaging part is concerned, we localize it, we see the extent, and then we take a small sample, help the physician to take a sample, and then they see under microscope. Now, there are lesions which sometimes we cannot see even on ultrasound. So we see something on mammogram, and according to the mammogram, the features, it looks suspicious, but we are not seeing anything on ultrasound. So in those scenarios, we try to go for the MRI. And suppose on MRI also the lesion is diffuse and it's difficult to detect, but still we, considering the history, considering the appearance, it's still that lesion looks abnormal. There is something known as the needle localization. So under the guidance of mammogram or ultrasound, we place a thin needle in the lesion and the surgeon takes out the tissue around that needle surgically. So that's called a surgical biopsy.
Okay.
So once the lesion is out, they see it under the mammogram again, whether they were able to remove the whole lesion, and then they go for the histopathology. And if it is positive, then they treat accordingly.
Right.
So there are many ways we go with that, but definitely, again, in the whole scenario, as you can see, the emphasis is on the mammogram and the ultrasound.
Yeah.
These are the two modalities which go hand in hand to have an effective and early diagnosis. And if you're doing a diagnostic memo, to stage it to what extent it is involved, and accordingly make decisions in consultation with the surgical specialist.
Yeah. And I think overall what it speaks to is the importance of imaging in the entire process. So that, and like you said, I think, and even like Monisha mentioned, you have a team here that has a lot of experience and can help to guide people through that process. So as we wrap up, I want to go back to the idea early on about early detection, and maybe just jump back a step to say, in the prevention space, are there any lifestyle or environmental factors that women can undertake or change to reduce their risk of breast cancer? And I guess, how does early detection even tie into prevention efforts?
Right. Before I get into that, I just wanted to add a couple of numbers to the previous,
Sure.
because I think the patients or the general public should be aware of that. So, by statistics, which is American statistics, but I think we differ a little in the Bahamas here. If 100 women come for mammogram, screening mammogram, uh, the American stats say 10 of them, that's 1 in 10 essentially,
Mhm.
are going to need some additional investigation,
Okay.
right? Which may be spot mammograms, compression views, maybe magnification views, maybe an ultrasound. But I would say in the Bahamas, because the dense breast scenario, the significant family histories, and the early screenings which we start at, I would say we are at about 30 patients in 100
Yes.
would land up having an additional imaging
Yes,
modality
yes.
or a tool,
Mhm.
because you want to complement screening and be able to detect early cancer. Beyond that, you definitely need to know that there are going to be about two of them who are going to need 6-month follow-up. So that's a Barrage 3 category. That's the American standard, but I would say we probably in the range of 5 of them needing to come back in 6 months for imaging to confirm that the lesion is stable or truly there, right? So those are those ambiguous gray zones which neither fall in the benign or the malignant category. And then again, by American standards, they say 2 of the 100 are going to need biopsies. I would say 2 is not inappropriate, but yeah, I think in the Bahamas we'd be forced to be in the range of 3 to 4 per 100, which might need biopsies, because you do see a lot of atypical cancers, which are essentially, for example, you want to call them benign fibroadenomas or intramammary lymph nodes, which look very well defined, small lesions, and you go to biopsy them and they are actually early cancers. So you can't completely rely on appearances. Sometimes patients' age and demographics will still determine the need for a biopsy to confirm that this is benign. So those numbers are important, because it still tells you that about 70 to 75% of the patients who are walking in, that is the end investigation. Nothing's going to happen after this, right? You just come back next year for a screening mammogram. But about 25 to 30 of them are going to fall in the group of having additional exams or follow-up exams and thereafter biopsies, uh, in progressively smaller percentages.
Okay.
So I just
Understood.
wanted to get that out there,
Mhm.
because that's not that should not be a reason for you to not come and get screened. Talking about environmental factors and lifestyle factors, and we did speak about the genetics of it. And like I mentioned, the BRCA1-2 mutations have a high percentage of prevalence in the Bahamian population. But beyond that, there are many lifestyle factors which affect the incidence of breast cancer. Some are modifiable, some are not. Like I mentioned, being of the female gender already puts you in average risk of breast cancer, right? That does not mean that males do not have breast cancer. That's again a common myth as well. It's not a big percentage, 1% about, so 1 in 100 breast cancers which are diagnosed is in a male. But the problem is that because men consider themselves immune, they're less likely to pick it up, and therefore they are diagnosed usually in the later stages, which is detrimental for the outcomes. Um, the age group, again, you can't modify age group. Once you slip into the 40 to 74 age group, you have to have screening. It's something which is natural progression, and that's a necessity to evaluate. Some of the other trends which are happening nowadays, and it's actually a worldwide trend, which is lower age at menarche. So menarche used to be about 13 to 14, uh, let's say just 2 decades ago, and you're seeing that the age at menarche is going down, which is the time when a female has her first periods. right? And that's going into the ages of 9 to 11 and even smaller. So lower age at menarche, which is happening a worldwide trend, is one of the risk factors. Late age at first pregnancy is a known risk factor. So again, the trends are that more women tend to have their first pregnancy beyond 30s, which puts them at a higher risk. Fewer pregnancies, as well as inadequate breastfeeding or no breastfeeding during a pregnancy, puts a female at a higher risk of breast cancer. So breastfeeding is a protective against breast cancer. Uh, Obesity and alcohol, yeah, so those are again lifestyle factors. Obesity is, for all practical purposes, a pandemic in the Bahamas. uh, we are, I think, if I'm not wrong, this third highest right now in terms of obesity. And it's interesting that all of the top countries, if it might be the seventh, but all of the top countries in the obesity population prevalence are islands. A lot of them are islands. Um, Especially, I think the Pacific Islands have a very high percentage. So definitely lifestyle modifications where you're active, you have an appropriate BMI, and you reduce alcohol intake are risk factors which you can control, and are something which we should promote as a healthy living. So yeah, I think those are the common environmental factors which are worth discussing, and it's important to be aware of those, which reduce your breast cancer risks.
Yeah, so you were right. We're number 7 based on data from 2022, with an obesity rate of 40%, 47% of adults over 18.
Yep.
So obviously that is an important one.
That's 7 out of 210 countries, I guess. So that's
Yeah,
pretty high.
it's pretty high, especially considering we have such a small population.
Yep.
So and again, it's one of those things, like you said, is modifiable, right? And I think that's where that question really goes, is the idea of what are some things that people can actually change to help and reduce that risk. So obviously, like I said, we're in October. Dr. Sharma, can you just give us an idea of what the promotions are that are going on with regards to breast cancer screening during the month of October for our listeners?
Yes, we are very pleased to continue our annual promotions for breast cancer screening at 50% discount for screening mammograms. And like I mentioned, this year we are actually switching over to the new 3D tomosynthesis machine. So that is, I think, a great price point at $60 a mammogram, which is, I think, definitely affordable, and that's something which we would like to ask all women to take the advantage of. Beyond that, we are also looking at offering promotion prices for breast ultrasound. At that, I would like to mention we have an automated breast ultrasound called an ABIS machine, which is essentially doing a 3D image of the breast. So normal traditional ultrasounds are 2D handheld, which we can also use to complement a 3D ultrasound. But the ABIS is able to take the whole volume of the breast in a screen, and we can even look at it retrospectively through that data set. So it has some advantages which over and above routine handheld ultrasound. So we'll have promotion prices going at $100 a breast exam and $250 for both breasts for the ABIS exam. Last but not the least, there is a common trend that a lot of women become active in screening later in October. So we inevitably extend our promotions into the months of November and December. So this is a promotion which is not just for the month of October.
Right.
It is a 3-month endeavor, and we aim to accept and capture as many women in the screening population as we can, so that we can detect cancer early and improve the outcomes for those ladies.
And I think one final reminder in the promotional space for our LAMP members, you have the ability to get your mammogram for free, and you can also get and or for your mother for free. So we do have that as an additional layer of promotion for mammos as well.
Excellent.
I want to thank you, Dr. Sharma, Dr. Pahwa, and Monisha for joining us today on the Doctors Hospital podcast. It's been a great conversation. I think a lot of really helpful and beneficial information for our listeners. And I just want to thank you for taking time out of your busy schedules to be with us here today.
It's been our pleasure. Thank you, Alexis, for having us.
And, as always, we invite you, our listeners, to like, comment, subscribe, and share. And we will see you back here next week on the Doctors Hospital Podcast.
Your health just got brighter with Lamp Insured. Sign up for Doctors Hospital's Lamp Insurance Supplement Plan and enjoy copay waivers and complete access with no upfront ER or inpatient collections. Only $30 per month. Visit doctorshosp.com/lamp to sign up or contact 242-822-1009. That's 242-822-1009. Your journey to affordable and worry-free healthcare begins now.